undergo that stem cell transplant will be cured. Yes? Plasma cell myeloma, because it affects the plasma cells. So, possibly due to genetics, environmental exposures, toxins, radiation, really slow and insidious onset, greater incidence in men than women, and greater incidence in African Americans than Caucasians. So this disease process involves an excess production of plasma cells. So normal plasma cells are activated B cells. They make immunoglobulins or antibodies that protect the body. In multiple myeloma, they make, instead of a variety of these plasma cells that are going to attack a variety of infections, different infections, myeloma tumors make monoclonal antibodies. The problem with that is monoclonal means there's only one kind, and that means that they can only fight one type of infection. So this really makes them ineffective and harmful. So instead of having plasma cells that are going to go fight whatever we got going on, we have this monoclonal antibody that's really going to be ineffective and harmful. So not only are they not fighting infections, but then they start to infiltrate, they're infiltrating the bone marrow. Okay? So these monoclonal proteins are called M proteins. They're made up of two light chains, two heavy chains, nobody knows that, but I say that because the light chain portion of these are Vince-Jones proteins, and this may show up in the urine of patients with multiple myeloma. So if you see Vince-Jones proteins, we're going to associate that with multiple myeloma.
If the Vince-Jones is in the urine, is it like a genuine habit?
I think we still need to do some like biopsy and things like that. I don't think that's necessarily definitive, but it is, because it may show up, may not. But if you see the Vince-Jones protein associated with multiple myeloma. Okay. You guys good on that? Okay. So slow and insidious onset. And the patient really, they won't have symptoms until this disease process is more advanced. So skeletal pain is going to be a major manifestation. They'll have pelvis pain, spine pain, ribs. That'll be pretty common. It'll be triggered by movement. And then in X-ray, you'll see these multifocal osteolytic lesions. You see these radiopacities here? You see that? See this bone? We're going to see those on X-ray. Did you guys see that over here? Okay, vertebral destruction can cause the vertebral collapse. So, if we have this bony degeneration, what's going to happen to the calcium that was in the bones? Right, it's going to cause hypercalcemia. Good job. And hypercalcemia can cause what kind of damage? What filters out? Renal. Yep, kidneys. We can have renal damage. We have GI problems, neurologic problems, cardiac problems, heart problems, confusion, anorexia. All of that is caused by that hypercalcemia. So this is care to relieve some of the symptoms. So chemotherapy, corticosteroids, targeted therapy, maybe try bone marrow stem cell transplant. We need to be really, really careful moving these patients. I mentioned that they have bone pain, so be very careful when we're moving them. Pain management. We all know, you guys know that weight-bearing exercises can help the bone reabsorb calcium. So if these patients can tolerate it, having them do some weight-bearing exercises. And then fluids, why? Dilution, right? Dilution is a solution to pollution. There you go again. Okay? So we want them to have a urine output of 1.5 to 2 liters a day. Okay, osteosarcoma. This is an aggressive bone cancer. Most often going to see this in children and young adults, typically males aged 10 to 25. They have a higher incidence of this in those that are exposed to radiation, so radiologists, radiation chemists, uranium miners, people exposed to radiation. And then the symptoms are gonna include pain and swelling of that area. If you see, this just gives me the heebie-jeebies, but it's a cool picture. You can see that lesion on the outside of the bone, right here. It's really cool. But when we talk about cancers that metastasize to the bone, they're gonna cause the same kind of complications that we'll talk about with osteosarcoma. So treatment, so surgery, they can amputate the limb, or they do limb salvage. You guys heard of what limb salvage is? This is really cool. They go in and they remove the part of the bone that has the cancer, and then they can replace it with like a donor bone or an internal prosthetic. So like if they did a salvage surgery on the leg, they would take that bone out, replace it, and the patient, it may take them up to a year to begin walking again, but we can salvage what's left of that leg. Pretty cool. Lots of physical therapy involved with that. We're doing chemotherapy, radiation. We want to prevent pathologic fracture, so really careful handling of these patients. We want to support the affected extremity, gently log roll the patients to their own bed rest, and then lots of pain control. And then here we go with our calcium again. Gotta watch that. We're gonna be monitoring their heart rhythm because calcium has an effect on that. And we're watching our serum electrolytes. And again, metastatic bone cancers are gonna act the same way. This is the distribution of the common osteosarcomas where they commonly occur at. Most of the time, there's different types. There's chondrosarcoma, chordoma, osteosarcoma, and sarcoma, and where those occur at most often. Okay, oral cancers. So we have oral cancer. The oral cavity cancers are going to be in the mouth, and then we got oral pharyngeal cancers, and that's going to be in the part like the throat just behind that. Okay. You might hear a broader term called head and neck squamous cell carcinoma. That's common. And that's kind of a blanket term for all the cancers of oral cavity, the pharynx, and larynx. You guys see the cancer on this patient? Right there. Okay. Risk factors. Tobacco use, prolonged alcohol use, outdoor occupations. Why outdoor occupations? Radiation from the sun, right? On the lips. Okay, so we'll consider the lips part of that. And then HPV. That's sort of newish that we're talking about HPV. In my world, it's not super new, but I feel like it's becoming, just now becoming more common to the layperson that HPV can cause oral cancers. Most common sites for oral cancer is going to be the lower lip, obviously because of the sun, and then the lateral border of the tongue, so that's the side of the tongue, and then the ventral surface of the tongue, which is the underneath of the tongue, and then the labial commissures, which is the side of the mouth, and then buccal mucosa. That's kind of the order that they go in. So signs and symptoms of this. If a patient has a mouth ulcer that doesn't heal, we're gonna start looking into it. We're gonna send them off to a biopsy. If someone comes into my office as a dental hygienist and I take a look and they say, you know, I've had this sore for a couple weeks, or if it's a couple weeks, I might say, you know what, if that's still there in 3 to 4 weeks, I want you to give us a call back, and then we're gonna send you to an oral surgeon and have the biopsy and look at it. If they come in and they say this, and we say, oh, what is this spot? And they say, I have no idea, I haven't seen it, don't know how long it's been there, I'm probably gonna go ahead and send them to an oral surgeon to have them biopsy that to look at it. So any mouth ulcer that doesn't heal, we're gonna be questioning. A white or red patch in the mouth, increased salivation, dysphagia. What's dysphagia? Difficulty swallowing, good job. Or any neck mass. So I talk about, this is a little soapboxy for me because of my background in dental hygiene. As dental hygienists, we go through a whole class of oral pathology, and we are taught what's called the head and neck exam, the extraoral, intraoral exam, the EIE. And I can bet that a majority of you not have experienced this in your dental hygienist chair because of the lack of time, unfortunately. But it's something that we are taught to do where we actually palpate every surface of the face. It's kind of awkward to do. You're sitting with a patient and you palpate palpate down their neck, you feel these cervical lymph nodes, the lymph nodes in front of here. That's how we're educated. So anything that we see as off, we're gonna become concerned about. And I really, really wish that dentists and hygienists put more, I don't think that it's that they don't put value in it, it's the fact that nobody wants to sit there for an hour and a half to get their teeth cleaned. And so they might become annoyed at that. But they should at least be doing an intraoral exam, looking for any white patches, anything that doesn't look right. And if you have a patient that comes to the doctor's office or the hospital and you're looking at, you have that white patch there, how long has that been there? And they're not sure, then we need to become curious about it. Just because it's in the mouth doesn't mean it's not our wheelhouse as nurses, right? We become curious, we ask about it, right? Okay, so for these patients, we do radiation, chemotherapy, we can do surgeries, they can do a laryngectomy, radial neck dissection, and with these surgeries, these patients are gonna have a tracheostomy, and so we're worried about maintaining a patent airway, and then pain control is a concern for these patients. Have you guys seen, these used to be really popular when I was younger, and you go to the dental office and they'd have like pamphlets, and it was the guy who had his entire jaw taken off because he used smokeless tobacco. Have you guys remember those?
Yeah.
I cannot find a picture which saved my life. And I actually knew somebody growing up who had to have, because of smokeless tobacco, they had to remove the entire lower jaw, which is very disfiguring for the patient. Do you guys like gross stuff?
Yes.
Okay, cool. I'm gonna share it. You don't, throw it. Because it's fun. It's cool. If I get to it. Okay. So, this, I don't like this browser. Let's see if we can zoom in. Okay. Okay. This patient had a squamous cell carcinoma on the right lateral border of her tongue, which is the side of her tongue, here. Okay, it's gonna be down here probably. And so they went in. How do you think they got this image here? They didn't pull her teeth, because this is her afterward.
They went in here.
Huh?
They go in there?
Yep. Transcervical approach. So they're gonna come here and then flap up. Okay, this is interesting. This is cool. So you see right here, that's that primary site. So this is a partial glossectomy, so they took off half that tongue. And then this, right here, is a flap taken from her forearm and reconstructed the tongue with it. Isn't that wild, the things we can do? So this is a frontal view of the same thing. So this is her tongue prior to, then they removed it. This is the specimen. This is 2 weeks post-operative. Pretty cool. Isn't that cool?
So if this happens, they're gonna have to have like a lot of speech therapy.
Yeah, they'll probably need some speech therapy. Obviously, they lose their taste in that part of the tongue. But isn't it impressive how quickly that's 2 weeks post-op, and that looks that good? Here's this flap. This is super cool. Here's another one. So her cancer is here on the dorsal surface of the tongue. They did a total glossectomy for her. So what's left of her tongue is just the base here. And then they used her left radial forearm free flap as a neo-tongue. So there's the specimen. Isn't that interesting? So imagine what we as nurses might have to do for these patients for nutrition while they're healing from all this. Even once they're past this patient has now lost all of her taste buds, right? And obviously she doesn't have, it's like they extract through there, but okay. I just like it. I think that's cool. Isn't that cool? Isn't it cool what we can do though? I've seen patients that will actually like grow hair in their mouth because they use skin that they grew hair.
You.
Yeah.
You shake your tongue.
Doesn't know.
Isn't that interesting? So really interesting things, really interesting treatments that they can do for these patients. I apologize if that's too graphic. I just think it's incredible the things that we can do. Okay, esophageal cancer. Esophageal cancer, obviously cancer of the esophagus, very fatal cancer. Has a really high incidence in white males. The 5-year survival rate for this is less than 20%. The esophageal, I'll show you. I'll send the procedures I do. So the incidence of this is going to increase with age. Have you guys ever heard of Barrett's esophagus?
Yes.
Patients who have GERD often have Barrett's esophagus, and when patients have Barrett's esophagus, they will be going in and doing endoscopic surveillance fairly often, like every 3 to 12 months, just to check to make sure that we haven't moved over to having something cancer, right? So, patients who smoke, excessive use of alcohol, any injuries to the esophageal mucosa from occupational exposure, like asbestos, cement, dust, things like that. That's why it's really important that people in those occupations are wearing their masks. Signs and symptoms, so progressive difficulty swallowing, pain, sore throat, they start choking on their food, like all of a sudden, like, or not all of a sudden, but gradually it's like, oh, I can't quite swallow things of that texture, or something like that. That's something to be concerned about. They may start to be hoarse, weight loss, and they could also hemorrhage. This first picture is of squamous cell carcinoma of the esophagus, and the second one is an adenocarcinoma of the esophagus. Pretty yucky looking, huh? So that's why we have to look at these patients that have this Barrett's esophagus to make sure that it hasn't progressed. So what we can do for these patients, there's some endoscopic procedures that we can do. I just looked this up to see what endoscopic procedures they might be doing. There's something called photodynamic therapy. You guys don't need to know the details. It's just, again, interesting these things exist. It's important to kind of have a well-rounded idea of what they are. So photodynamic therapy, the patient receives an IV of porphyrin sodium. So all tissues will absorb that chemical, but cancer tissue absorbs it to a greater degree. And then the provider will direct a light toward that cancerous area. They'll use a fiber pass through an endoscope, and that light will react with that porphyrin sodium chemical, and it'll start a reaction that starts to kill the cancerous cell. Kind of cool. Patients will have to avoid sunlight for up to 6 weeks after that procedure. There's also called EMR, which is an endoscopic mucosal resection. So very early stage esophageal cancers, they can go in and remove it using an endoscope. There's also radio frequency ablation, and they're going to use electric currents to kill cancer cells by heating them up. Now this is if we catch them pretty early. We can also do surgery. We can do an esophagectomy. This is a really major surgery, really high risk of complications, and it's got a 10% mortality rate, 30-day mortality rate. This is like a 5-second little video to show you why.
Esophagectomy. Part of your esophagus is removed,
Okay, so they're removing the
along with the top part of your stomach and nearby lymph nodes. These lymph nodes can capture bacteria, viruses, and other harmful material, including cancer or other abnormal cells moving through your body. Typically, the remainder of your stomach is then pulled up through the opening in your diaphragm, called the hiatus, and attached to the remaining part of the esophagus.
What happens to the stomach? Much smaller. So really high risk of complications. There's bleeding, infection. The patient coughing can cause big issues. Leakage from that surgical connection of the esophagus and stomach can cause major issues for patients. They might experience a change in their voice. Probably going to have some acid bile reflux issues, nausea, vomiting, diarrhea, respiratory complications, dysphagia, death. Okay? Imagine all the complications that could come from removing that esophagus. You shorten that stomach. The digestion is not happening like it should be, typically. These patients will have a feeding tube for at least 4 to 6 weeks following the procedure, if not longer, to maintain adequate nutrition. Smaller stomach means that patients can have to eat more frequently if they are able to eat. Very small, frequent meals, because that's all they can tolerate. Typically, I've heard of patients having a feeding tube. why it's been longer than 4 to 6 weeks.
So what happens to the stomach acid, the stomach veins? It's pulled up and-
They're gonna experience that, it's going to be,
Like they're up here and
yeah, they'll be burning, yeah.
So the will start breaking down here.
That's wild.
I mean, you start breaking down food the moment you put it in your mouth, your saliva starts digesting it, but yeah, it's gonna go straight to your stomach, and imagine how much you could tolerate with that, right? Okay, so nursing management, maintaining airway is a big deal. Think about, you know, the length of the esophagus, if we cough, if we choke, we've got room there. Now aspiration might become a bigger issue for these patients because of their new anatomy. Okay, so assess and assist in oxygenation, pain control, NG or gastric tube management. With patients, you guys know this, if anybody's had a gastric surgery of any sort, we are not dropping NG tube on these patients, right? Physicians need to do it, providers need to do this. So they're gonna have an NG tube, gastric tube. Do not manipulate it. We do not want to be instilling an air bolus. The diminished capacity of their stomach, that could be really, really painful, really dangerous. So once that is approved, the NG tube is approved, we're not instilling that air bolus. We're not manipulating it at all. If we're concerned that it's moved out of place, we have to obviously get that checked via x-ray, okay? Parenteral nutrition possible for these patients, and then, like I said, enteral nutrition. When we're talking about enteral nutrition, down here you got your gastrostomy, jejunostomy, just so you guys know where those are located. You don't need to know these details, that's just for your reference. That's from chapter 44 of your book. Those are just common tooth placements. Okay, everybody good on esophageal? Any questions? Okay. Pancreatic cancer. So really high mortality rate. The 5-year survival rate is 9%. Most patients will die within 5 to 12 years, or months, sorry, 5 to 12 months of diagnosis. Typically, these patients are diagnosed about 71 years of age. Most of these are adenocarcinomas, very, very poor prognosis for these patients. Risk factors, somebody who has chronic pancreatitis, diabetes, older in age, cigarette smoking, there's a family history to it potentially, high-fat diet, environmental factors, somebody who has cirrhosis is at a higher risk, males tend to be at a higher risk, and then diabetes mellitus, I have that one twice. Right, signs and symptoms. Abdominal pain, this could be boring back pain as well. It's going to radiate to the back, and sometimes it'll be relieved by sitting up, more severe at night typically. Anorexia, they just don't feel like eating. Weight loss, nausea. A late finding with this would be jaundice. Patients are dealing with fatigue, and they might have pruritus. What's pruritus? It's like uncontrollable itching caused by the buildup of bile salts. Okay. Their stools may be clay colored. They might have dark, frothy urine. They may be experiencing ascites. You guys know what ascites is? It's like that fluid buildup in that peritoneal cavity looks almost pregnant. GI bleeding and flatulence. So to diagnose this, we want to use a biopsy to diagnose this. They can do an ERCP, which is an endoscopic retrograde cholangiopancreatography. It allows us to see, they'll see the pancreatic duct, the biliary system. They can obtain tissue and secretions for biopsy. We do abdominal paracentesis, and then obviously imaging, ultrasound, MRI, CT. So the Whipple procedure is it's also known as a radical pancreaticoduodenectomy surgery. But the Whipple, we'll call it the Whipple. It's the most effective. Only about 15 to 20% of patients have resectable tumors at the time of diagnosis. So typically at the time of diagnosis, it's gone beyond being able to resect it. So those who can get the Whipple procedure, only about 15 to 20% of patients. Okay. Chemotherapy, radiation has a really limited role. They're typically used to shrink the tumor so then that they can go in and surgically resect it. Radiation, they may use external beam radiation or implanted beads. So my dad, he had a duodenal adenocarcinoma, but they treated it like pancreatic cancer. So he went in and did the Whipple procedure, had the radiation implanted beads done, all of that. So, but this is what happens during the Whipple procedure up here. So they remove most of the pancreas, and then I honestly, you don't need to know details. It's a lot, but that's what the Whipple procedure looks like. Just know, Whipple procedure, we're gonna associate that with pancreatic cancer. And if they get the Whipple procedure, they're not as far advanced in their pancreatic cancer, which is a great thing. Okay. Any questions on pancreatic cancer? Y'all still on the bus with me? Good? Okay. Okay, breast cancer. Most common invasive cancer in women, second leading cause of cancer death in women. Increased risk after the age of 60, more common in Caucasian women, though there's a higher mortality rate in African American women. Risk factors. So we talked about those gene mutations, the BRCA1, BRCA2, and there have been others that have been identified. But just recognize that. And notice only 5 to 10% are because of that gene mutation, and we talked about the genetic predisposition to cancers and those things. Early menarche or late menopause. Anybody know why? Or take a stab at why? Hormones, yeah. Hormones, good job. So most GYN cancers, ovarian, breast, endometrial, etc. If you have a high exposure to estrogen over a lifetime, so like unopposed estrogen for a really long period of time, leaves you at a higher risk for these type of cancers. So for instance, if a girl starts her period at the age of 11, and she doesn't go through menopause until the age of 60, that's a lot of years and decades of estrogen unopposed, right? She's exposed to estrogen during that entire time. So that's gonna put her at a higher risk for breast cancer. So when you get pregnant, that kind of gives you a little bit of break to that exposure of estrogen. Breastfeeding gives you a little bit of a break to that estrogen as well. So women who didn't have children, didn't breastfeed, are at a higher risk for breast cancer because they're exposed to more estrogen. Does that make sense? Okay. Weight gain, obesity after menopause. Our diet plays a role in it. Hormone use, radiation, lack of exercise, and then pregnancy variation. So nulliparity of the first term pregnancy after 30. What does that mean? Y'all just did OB, right? So it's the first pregnancy after the age of 30, so that's going to increase their chance for breast cancer. Because they've gone a really long period of time, so maybe from the age of 11 to 12, 11 years old to 30 years old with unopposed estrogen exposure. Yes?
So just like oral contraceptive, is that put you at risk because you're taking a combination?
But I don't think it's that huge of a thing, so they wouldn't give you. Okay. Signs and symptoms. So no longer, the self-breast exam is no longer in the guidelines. Do you guys know this? They're
No.
not recommending the self-breast exam anymore. So they're saying that there's not a lot taught that way. There's a lot of false positives. People experience that they end up being nothing, and they're not finding that it's effective, so they're just not recommending it anymore. But signs and symptoms: any non-tender, non-mobile, hard lump, nipple discharge, retracted nipple. Do you guys know how to say it? Anybody speak French? You speak French? Can you say that bad fourth one? Oh, that's beautiful. I would say eau d'orange. She says it so beautifully. I love when people can do that. So that is this orange peel look to the skin. It's kind of that dimpled look. You might have redness and warmth, axillary or supraclavicular lymphadenopathy. And you guys know what those words mean? Supraclavicular, above the clavicle, lymphadenopathy, swollen lymph nodes. And axillary, where's that? Armpits. Okay. So, sites of breast cancer. So this is the distribution of where cancers most typically occur. So most of the time they're located in the tail of Spence, which is this upper outer region where the lymph nodes are. So this 50% up through here is where most of them, are you guys seeing this? The tail of Spence in the axillary region, upper outer region, okay, where the lymph nodes are, close to the armpit, that's where they're typically found, okay? So we discussed Angelina Jolie, feels like it was years ago, so she had the nipple sparing surgery, so that's that 18% risk that she still has over her lifetime of developing breast cancer. Okay, see how that works? Okay, diagnosing, we can use mammography, ultrasound, they might use a breast MRI, and then obviously the gold standard is going to be our biopsy. So, according to the American Cancer Society, our screening schedule with annual mammography is being, it's really debated right now. They're saying beginning at 45 or earlier if you have any risk factors. So, familial risk factors, things like that, you can start earlier than 45. But it's really being debated right now, the screening schedule for patients ages 40 to 49 because there's a high false positive rates. So, American Cancer Society says 45 years old is where you want to begin, unless there's some risk factors, and then it's before that.
How far before that though? Like 40?
Okay, so they may do a lumpectomy, so they'll go in and just remove that tumor. They can do a modified radical mastectomy, radiation, brachytherapy. We talked about some of these chemotherapeutics, hormone therapy, biologic and targeted therapies. We talked about those. And then they might do an axillary node dissection. So let me ask you a question. Do you want a HER2 or like an estrogen receptor positive breast cancer, or do you think you would want a triple negative breast cancer? Why?
It's more sensitive.
Right, yeah, good job, guys. So if it's triple negative, that means that it doesn't really respond to anything. There's no overly expressed HER2, it's not estrogen receptor positive, it's not progesterone receptor positive, so it's gonna be a lot more difficult to treat, rather than if we know that it's estrogen receptor positive breast cancer, we can go in, block that estrogen, and that's gonna be how we treat it. Does that make sense? So if it's triple negative breast cancers are much harder to treat because we can't take that one thing that they are using to grow. So sentinel lymph node biopsy. So no longer are we gonna go in and we're gonna remove every single lymph node that we see in there. Now they can go in, they can inject a dye before they do the surgery, and then remove the tumor, and then they can see where that dye has traveled to through the lymphatic system, and they can just go and remove those nodes that are the first responders from that area. So saves the patient from lymphedema, and I'll show you a picture of lymphedema here in a second. So nursing interventions, again, pain management, common theme, coping enhancement. So identifying sources of support for these patients. Knowing those community resources that are available for these patients is a really big deal so that we can refer them to those. Body image enhancement, if they're gonna have a mastectomy or even a lumpectomy, can cause some body image disturbances for these patients. Education, so procedures, self-exams. Like I said, self-exams aren't highly recommended, but it's good for us to know how to do those in patients that are at a higher risk. Might be something we can suggest to them to do, but again, not officially recommended. So affected arm. So when we go and remove those lymph nodes from that affected arm, we want to make sure this patient's doing exercise therapy, decongestive therapy, elevation. They'll be wearing compression garments. I think I have a picture of those here in a second. And we saw during the Kahoot that patient had a limb alert band on. That's for these patients. So on whatever affected side it is, they may have a limb alert. They may have a limb alert on both sides. Okay, so we're gonna have to get creative. But no injections, IVs, or blood pressures. Nothing invasive, nothing non-invasive like blood pressure. on the affected lymph. This is lymphedema. Okay, so this is accumulation of lymph in the soft tissues there. So the lymph system, it carries away fluid, dumps it back into the cardiovascular system. So if someone's lymph system, if we take that out of their arm, it makes sense that they're gonna have pain, they're gonna have this swelling, higher risk of infection in that extremity, okay? So this is what lymphedema looks like, okay? So no blood pressure, no venipuncture, no injection on that affected side. We don't want them to have their arm ever be dependent. We want to avoid injury, trauma to that arm. These patients will have, I thought I had a picture of it, it's like a stocking compression. Usually they're like skin colored, and they will wear them to create that pressure on them. Exercise, maintain healthy weight, important teaching for these patients. And they will wear those stockings all the time. Or those compression garments, I should say, not stockings. Okay. This is, okay, colorectal cancer. So these are cancers of the colon or the rectum. So this is the third most common invasive cancer, there's a typo, in the U.S. Second leading cause of cancer-related deaths. And the mortality is highest in African Americans. Risk factors. Male, age 50 plus, but this number has slowly been decreasing, and the number of people diagnosed between the ages of 20 to 49 is rising, and it's expected to continue to rise. Okay, so that's not the only, that's changing, okay? A family history, someone who has had colorectal polyps at a higher risk, patients who have IBD, a poor diet, they say like red meats, things like that, smoking or alcohol, obesity, and diabetes, all risk factors. So signs and symptoms can be different from the left side to the right side, which seems really, really odd, but it's related to the location of the cancer and the anatomy of the colon in that area. So bleeding is going to be more common on the right side than on the left side. The left side will be more rectal bleeding versus the right side might be higher up bleeding. So the right side of the colon is wider than the left side. So these cancers can go unnoticed for a longer amount of time because there's more space to mask those symptoms and signs as it grows. So like the pain and the rectal bleeding. Obstruction may not happen as quickly because there's more space in that, okay? So left-sided would be pain, rectal bleeding, obstruction, narrowing of the stool. And then right-sided, it can be asymptomatic for quite a while. They can have abdominal pain, they may end up with a mass there, occult bleeding, and anemia. Okay, so screenings for colorectal cancers. So somebody of an average risk, our gold standard is always going to be our colonoscopy. And we're going to start that at the age of 45. And then they will have those done every 10 years. Someone who is at a higher risk, we're going to screen earlier and we're going to screen more often. Okay? Bless you. So someone who has 2 first-degree relatives that had colorectal cancer, they're going to get a colonoscopy every 5 years, starting 10 years prior to the youngest relative that was diagnosed. So if their relative was diagnosed at 40, then they're going to start getting their colonoscopies at 30, and they're going to go every 5 years. First degree, if they had 1 first-degree relative with colorectal cancer after the age of 60, they're going to have a colonoscopy. They should have a colonoscopy every 10 years, starting at the age of 40. Now, in my family, I am at a higher risk because of my dad. He was diagnosed at the age of 45 the first time that he had cancer. So I had to start getting colonoscopies at the age of 30, which is oh so fun. At my first, I think I've got 3. The math doesn't math out because I had to get an extra one. But on my first one, they found a polyp on me. The prep is awful, but I talked about colorectal polyps being a risk factor for getting cancer. So these polyps can turn into cancer if we're not catching them. So that's the importance of having these colonoscopies, which I tell you what, they are not fun. I'll say this. The Prep for them is not fun. The procedure, I have no idea what happened. I was sleeping, and I came out with a really, really good nap. So, I like to get on my soapbox a little bit here because this is one of those taboo topics that people don't like to talk about. I mention my mom often because she's one of those people that's like, if I don't know about it, I'm good. The moment I find out about it, then I'll die really fast once I find out. Like that is her MO. It's very obnoxious, very annoying. She has some stuff with her thyroid. It's just like, I don't know, like her thyroid, like she has a goiter. We'll talk about goiters. She doesn't have the goiter anymore. So if you see pictures of goiters, my mom does not have a goiter, but she had a large thyroid. And so it's just like, it's fine. I'm swallowing fine. It's good. I'm fine. It's fine. So my mom is one of those people who just like, she will not go get a colonoscopy, no matter how much we beg her. But I think in this area, it's really, education is huge, right? We are educators. We're all educators. You're not standing up here like I am in the higher ed setting in academia, but you guys are going to be educating your patients. And not that we make a colonoscopy not a big deal, but kind of make it not a big deal, right? There's other diagnostic tools, and I joke about this. The first time I gave this lecture, I could not remember. Have you guys seen Cologuard? It's like the box that comes to you, and I jokingly called it poop in a box. So what is it called? You poop in a box. But that's one thing for our patients. If they're not at a high risk, they can do the Cologuard and they can test their sample. But it's really, really important to educate patients because if they don't get, say, their polyp found, like if I hadn't gone at the age of 30, I'm 36 now, I don't know. You know, I may have ended up where my dad ended up. So, really important that we're stressing this, kind of encouraging patients to do this. Like the prep is not fun. If you guys ever see anybody go through the prep after colonoscopy, it is just, you drink this disgusting drink, and they are cleaning out your colon, completely cleaning out your colon, until everything that runs through is clear. It is clean. And then they will go in, they'll give you some propofol, good meds if you need anxiety medication before because you're stressed out, they give you those too. And then you get propofol, which honestly, best nap ever. And you have no idea that it happened. They go do it, you come out, and I pop awake after propofol. Like I am, let's go, I'm ready, we're for the day, I mean, let's move on, right? So the prep isn't fun, but hey, good nap out of it. And then they'll come and they'll tell you your results. If they found a polyp, they'll go ahead and we'll just remove it while they're there. It's not an actual procedure, it's just gone. We saw it, we took care of it, and then we'll see you back in 5 years, for me. Other people at the age of 45, every 10 years, not that often, but some people have to have it. So if somebody presents and they're talking about, you know, a history of colon cancer, we get our medical history on our patients all the time. If you're working in a medical office, a dental office even, we will get those medical histories, and like, oh, you have a history of colon cancer in your family, so are you being screened? Is that something you've thought about? Because we probably wouldn't have done it had my dad's doctor not mentioned, like, hey, you need to have the girls make sure that they start getting colonoscopies at the age of 30, and then us 3 sisters are nudging each other every 5 years to make sure that we go get our colonoscopies. We should go together. Probably not a good idea. The prep in the same home is not a good idea. But just educate patients about that. You see something like that, any of these cancers, if there's anything, any screenings that maybe they need to do, we need to be on top of that.
You're higher risk, not just with colon cancer too, if there's a connection with the BRCA gene too, so breast cancer, ovarian cancer, so recommending more colonoscopies there as well.
There you go. Okay, so being aware, it's really important for us to know what is out there, even if we're not cancer nurses, right? We're not oncology nurses, but we can identify these needs, we can teach, we can do lots of education about it, okay? I'll set down off of my soapbox here. Okay, so surgery, the goal of surgical therapy, we're gonna be done really early today. I do have some questions for you guys at the end. Okay, the goals of surgical therapy. So we can go in, we can completely resect the tumor and get rid of it. Would be great. They can use surgery to go in and just explore the abdomen to see how far that cancer has spread. And then they'll go in and they can remove all the lymph nodes that drain that area where the cancer is located. And then the goal is that we can restore bowel continuity and promote a normal bowel function. Now that doesn't always happen, right? You know that. My dad, when he went in for his first surgery, fully expecting to come out, bowel function to be normal, it ended up being too big of a cancer, and so then he ended up with a colostomy. So recognizing that that's a possibility, and they told them that might be a possibility, but if it is, it'd be temporary, but it ended up being permanent for him. So we may not always be able to restore normal bowel function. Chemotherapy, they can go in beforehand, use chemotherapy to shrink the tumor before they have surgery. They can use it as adjuvant therapy after the bowel resection, or if it's a non-resectable tumor, we could go and use chemotherapy as palliative measures, right? Okay, adjuvant therapy, in this case, is always gonna be recommended after stage 3. If they're in stage 3, they are gonna do adjuvant therapy after that resection. Okay, radiation can be adjuvant therapy as well as palliative. Okay, that's the end of our cancer lecture. How are we feeling? You breathe. It's a lot, I know. I keep needing to bring my book up. When I go through these cancers, I took a single page per cancer and I wrote down what I needed to know about it. And I made myself a cheat sheet. And if I could fit 2 or 3 cancers on the same one, I would do that as well. But that way you kind of have less wordiness and more of the bullet points of what you need to know. And that's one thing that I did when I was studying for this, and it seemed to help me quite a bit. Okay, I got a few cancer questions for you, and then I want you guys, after we do that, we'll get into JTI, and make sure you guys make sure knowledge check that. It's cancer types. Yeah, those are the only topics. It's just the cancer to your knowledge. I don't have like a fun poll or anything for this one, so let's go through these cancer questions. We can think through them. I want you guys to read through these first and try to answer them, and then we'll talk through them. Okay, I see a few light bulbs going off. I see a few nods, like we got this. Okay, the nurse is reviewing the laboratory result of a client diagnosed with multiple myeloma. What is multiple myeloma? Say again?
Like the
Plasma cells in the bone, okay? Which would the nurse expect to know specifically in this disorder? We got A, increased calcium levels, B, increased white blood cells, C, decreased blood urea nitrogen levels, BUN, D, decreased number of plasma cells in the bone marrow. We want to answer A, why?
Breakdown of bone.
So that calcium is going to come out of the bone, right, into the circulation, and that's why we're going to see that increased calcium level. Our white blood cells, those are going to be decreased. Our BUN would increase, and the number of plasma cells, remember that's what multiple myeloma is, it's that overgrowth of plasma cells, so those would be increased as well. Okay? Read this one, see if you can figure this out. Talked about the same disease process, so multiple myeloma. So the nurse is creating a plan of care for a client with multiple myeloma and includes which priority intervention in the plan? So priority intervention. A, why?
solution of the solution.
Right. Solution is the solution to the pollution. We're worried about that calcium, that hypercalcemia leaking out. Okay? So they're going to be giving lots and lots of fluids. We want that adequate output of 1.5 to 2 but priority. Pay attention to that word. Which one is unique potentially to multiple myeloma, and what would I make priority? What's something that could be a really big issue for these patients, right? That renal issue with the renal system. Okay. Next one. Multiple answers here. You guys ready to discuss? Okay. When caring for a client with an internal radiation implant, the nurse should observe which principles select all that apply. Limiting the time with the client to 1 hour per shift. Do we want to do that? Why? Why don't we want to answer that one? Okay, we want to cluster our care. Why don't we want to answer that one specifically? Say that again. So it's that hour that's there, right? There's not a set time, right? It's as little as possible that we're in that room, but there's no set time on how much time we can spend in that room, okay? We may be in there an hour the whole shift, we may be there an hour and a half the whole shift, cumulatively, but there's no set time that we're giving you, okay? Okay, keeping pregnant women out of the client's room, yes or no?
Yes.
Okay, correct. We do not want pregnant women in there. Wearing a lead shield and providing direct patient care. Yes, that's our protection, right? That's our shielding. Okay, how about E? Remove the dosimeter film badge when entering the client's room. No, we want that on, right? That's measuring the radiation exposure. If we take it off, then we're not getting an accurate measurement. We don't know what our exposure level is. Okay, so always wearing that dosimeter. F, allowing individuals younger than 16 years old in the room. Now, we didn't talk about this specifically, but children younger than 16 years of age are not allowed to go in the client's room. Did I skip it? Oh, yes, placing the client in a private room with a private bath. Yes, okay. We want to reduce the amount of exposure to others, so putting them in a private room with a private bath is ideal. Okay, next one. We didn't talk about this specifically, but. Okay, you guys ready? While giving care to a client with an internal cervical radiation implant, the nurse finds the implant in the bed. The nurse should take which initial action? Okay? Should we call the health care provider?
No.
Should we? We
At
should.
some point.
Okay, we should call the healthcare provider. So maybe, should we reinsert the implant into the vagina? No, bad idea, right? They have to do that very, very carefully. We don't want to touch anything other than that tumor, and we are not skilled enough to do that. Okay, should we pick up the implant with gloved hands and flush it down the toilet? No, or bad idea. Okay, should we pick up the implant with long-handed forceps and place it in the lead container? Should we do that? So that's something that sounds like we should and could do.
Are we certified for
If we are certified to do it. Okay, so is it A or is it D? D. Why do we want it to be D instead of A?
It says initial action.
Initial. It's that key word initial. What's our initial action? So our initial action is to make sure that our patient is safe and to make sure that we are safe and the patient is safe and anybody in that room is safe. So putting that implant somewhere in a closed lead container where it is safe and away from other people, and then we can call the healthcare provider, and they can come and they can replace it if they need to, okay? When you're doing these questions, we have to read the whole question, because we can really easily jump to conclusions on this one. Because we'd be like, heck yeah, I'm calling the healthcare provider, there's radiation out, I'm not touching it, it's not my thing, right? Yeah, I'm gonna call the healthcare provider. Answer, done, move on in the exam. But we need to read all of our options to see if there's perhaps something a little bit better. Now, I could have not had D on there, and the right thing to do would be to call the healthcare provider, right? So read your questions, slow your brain down. I know, like, I'm one of those people, if I sit down at a test, my brain goes 100 miles a minute, I'm thinking of everything, the exam, my kids, my whole life, my car, all the things at the same time. But you've got to sit down, try to get in your zone, figure out if there's something for you that just like helps you relax. Is it breathing? Is it some sort of mindfulness? Is it focusing on something? Figure out what works for you so that when you sit down, your brain's not going crazy and you're like, initial action, implant in the bed, and health care provider, move on. Okay? I want you guys reading the whole question. See that it says initial action, and then read your options and decide which option is best. Take a breath, slow down. You have time. Okay? Let's read this one. Okay, you guys ready to discuss? Okay. The nurse should plan to implement which intervention in the care of a client experiencing neutropenia as a result of chemotherapy. What do we know about neutropenia? Risk for infection. Okay. What is low in neutropenia? Neutrophils, okay? Not just the white cell count, our neutrophils are low. Okay, should we restrict all visitors for these patients? No. Okay. Do we want to restrict fluid intake? Big no. How about, do we want to teach the client and family about the need for hand hygiene? Yes. Yes, that's a big, big deal. Do we want to insert an indwelling urinary catheter to prevent skin breakdown? Why?
Risk for infection.
Infection, right? Risk for infection there, okay? Hand hygiene, big, big deal, okay? Not all visitors are restricted. Who might we restrict? Someone is sick, okay? If someone has a known infection, recent known infection, they shouldn't be visiting, so we'll restrict them. Fluids should be encouraged, okay? And then obviously, avoid giving these people a catheter, give them another infection. Okay, read this one, see what you think. Okay, the home health care nurse is caring for a client with cancer who's complaining of acute pain. The most appropriate determination of the client's pain should include which assessment? Okay, is the client's pain rating, are we going to concern ourselves with that?
Yes.
Okay, how about nonverbal cues from the client? We can consider them, right? How about my impression of the pain that this patient has? No, it has no bearing on it, right? It doesn't matter what I think their pain is, okay? Definitely their pain rating is going to trump that. Pain relief after the appropriate nursing intervention. Now, we're going to assess that, right, after we intervene. That's an important thing that we're going to be doing, but that's not the subject of this question that I'm asking. Okay, so A, the client's pain rating is the assessment we're going to use. Okay, next one. admitted to the hospital with suspected diagnosis of Hodgkin's disease, which assessment finding would the nurse expect to note specifically in the client? Would this patient have fatigue? Probably. Weakness? Weight gain? More likely weight loss, right? Okay. So far we think A, B could be it. Enlarged lymph nodes? Yes. Okay. So remember, Hodgkin's disease, it's that the lymphoid tissue, it's a painless enlargement of a lymph node, and then it has its path that it takes. It progresses to the other sites. Weight loss, you guys identified that weight loss, not weight gain. They're probably going to experience fatigue and weakness, but specifically for Hodgkin's disease, enlarged lymph nodes. Okay, so you guys answered that right. Okay, go for this one. These questions won't be on your exam, so if you're hoping that I'm giving you some insight, I'm not. But these are good learning, this is a good learning tool. Okay, you guys ready? I'll give you a little bit more time. Okay, you guys ready to walk through these? Okay, let's walk through it. Facial edema in the morning. Okay, let me tell you this. I want you guys to write this down. These are some oncological emergencies. And maybe you don't need to write them down, just store them in your brain. Sepsis, DIC, SIADH, which you guys will talk about that in a few weeks. Spinal cord compression. Hypercalcemia. Tumor lysis syndrome. And SBC syndrome. So without even knowing all of that, we can kind of talk through a little bit of these. Does facial edema seem concerning to you guys? What are we worried about?
Airway.
Airway, right? Airway. So this sounds like that could be an emergency, right? If we have facial edema, we're compromised airway, emergency, right? Yeah, so we can be concerned about that. How about weight loss of 20 pounds in a month? Is this a concern?
Yes, but also normal.
It could be a concern. Is it an emergency? Okay. So this is not an oncological emergency, the loss of 20 pounds in a month, okay? How about serum calcium level of 12? Yes. What is that? Hypercalcemia. What is calcium levels? What are our normals? 9 to 11. I remember that as call 911. CAL 911. Call 911. 9 to 11. Okay, so that's above that. How about this serum sodium level? Are we worried about this? Why? Normal, right? Normal. How about our potassium level?
No.
Are we worried about it? What's your serum level? 3.5 to 5. I remember that as 3.5 to 5 bananas. Don't know why, just do. So potassium level, that's slightly low, but no emergency is going to happen with a 3.4 potassium level, right? Numbness and tingling of the lower extremities.
Yes.
Why are we worried about that?
Spinal cord compression.
Spinal cord compression. Okay? So we've established that facial edema, because airway, right? The calcium level is high, we're worried about that. And then the numbness and tingling of the lower extremities. So A, C, F. You have to walk through each of those individually and think, yes or no. When we come to select all that apply, and select all that apply could be 1. And we're not doing that to be mean. We try to mimic what the NCLEX does. And on the NCLEX, a select all that apply could be 1. They could give you 8 options and only 1 of them is correct. Okay? So don't feel like when you're taking your NCLEX, you're like, oh my gosh, it can't just be 1. How much will select this one just goes? Right? If you don't know that you know that you know, let's not select it. Some questions are the way that we grade them, it's plus minus. So you get points for what you answered correctly, but then they might also deduct points for something that you just guessed at. Okay? So when you get to select all that apply, know that you know, if you can. Go through each of those individually and answer that as a yes/no question, and then select it if it's yes. Okay?
What was the last one?
The numbness and tingling in the lower extremity.
After Taylor likes
SBC syndrome. You'll talk about that later. And yeah, they can have lots and lots of options. She just said that on her LPN exam, there were 10 options on select all applies. Okay, next one.
This isn't the next one. This is the same thing.
Oh, it's not. Sorry, guys. Hey guys, ready to talk through them? Give you a second. Okay, let's talk through it. The nurse is conducting a history and monitoring laboratory values on a client with multiple myeloma. We're back to that one again. What assessment findings should the nurse expect to note? Select all that apply. Okay. Are we going to see pathological fractures on these patients? Yes. Okay. Because of those proliferating plasma cells in the bone marrow, okay, pathologic fractures are going to be there. Okay. Urinalysis positive for nitrite. Yes. Okay. Hemoglobin level. No, it's normal. Calcium. Okay. It could be a little low, but pretty normal value. How about our serum creatinine levels? Is it fine? No. Okay. It's high. Why? What does creatinine have to do with? Kidneys. We talked about, we're worried about the calcium causing issues, right? Okay. So that would be an assessment finding we might find. guys ready to talk through this? First of all, what is this question asking you to identify?
What's not?
What the patient doesn't understand. Okay? And on these type of questions, on ExamSoft, you guys should be able to go in and highlight. So this might be a question that you want to highlight further teaching to remind you that they don't understand that. Okay? And you can even write it down on a piece of paper. This patient doesn't understand. So I'm going to have to do some reteaching. And these negative STEM questions are kind of hard, I think, to wrap your brain around what they're asking you to do. So if this patient states one of these, then we need to do some reteaching. Okay? So the nurse is teaching a client about risk factors associated with colorectal cancer. The nurse determines that further teaching is necessary related to colorectal cancer if the client identifies which item as an associated risk factor. So based upon the things that I said, the things that our book says, are people aged younger than 50 years old at risk for colorectal cancer? No. Based upon our book, now the numbers are changing, right? And we are always behind whenever our books come out, we're always going to be behind. We know, right, that younger and younger, it's becoming more prevalent among the younger and younger populations, but our book states that age older than 50 years is a risk factor. So if our patient states younger than 50 years is a risk factor, nobody over 50 years old gets colorectal cancer, would they be right in that statement? I just confused y'all, didn't I?
Yeah.
Sorry. Okay, so the patient states, if I'm younger than 50 years old, I'm at risk for colorectal cancer. That's not true. So they need some reteaching on that point. Okay? Typically, it's 50 and older. Okay? A history of colorectal polyps, is that a risk factor?
Yes.
Yes. A family history of colorectal cancer, is that a risk factor? Yes. Chronic inflammatory bowel disease, IBD, is that a risk factor? Yes. Okay? So when you look at these questions, these are ones hard to decode in your brain. Which one of these things does this client need more teaching on? Does this patient need more education on? Okay? So it was aged younger than 50 years. You guys okay? Okay. I was gonna tell y'all something about, okay, study. So we've got a little bit of time. That was the last one of those. When you guys are studying, I want you guys, we've got 30 minutes here. I'm not gonna chat at you for 30 minutes because I do want you guys to do your ATI thing, but give me just a moment of your time. When you guys are studying, I want you guys to study, learn the material, feel really good about the material, and then do NCLEX style questions. Did you guys all get that Saunders book with your books? Some of you did, some of you didn't. If you didn't, you can find all kinds of NCLEX style questions using like registerednursern.com has some great ones. I'm sure you guys know where to find those. Ask a friend if you don't, but go do questions and questions and questions. And don't just do the question and be like, yes, got it, move on. I want you to do the question and I want you to read the rationale. Why did you get it right? Even if you got it right, why did you get it right? Okay? Lots and lots of learning comes from taking questions, just like some of these questions today. Maybe you guys weren't ready for them because you haven't studied, but I think you guys got some learning and some valuable information from some of the questions. I really like to, after my lectures, follow up with some NCLEX style questions. I usually do it on Poll Everywhere. These